Hello, everybody. Good evening. I'm Dr. Howard Elkin, the medical advocate, and I'm so pleased that you're joining me tonight on YouTube Live. Now, many of you have noticed that I haven't been here for a few weeks. Actually, I have been here, but I've been preoccupied. I had a death in the family the end of November. My partner of several years passed away of advanced kidney cancer. So it was very scary and very heartbreaking. And dealing with grief, as many of you know, is not a it's a very difficult thing. And then I had back surgery on January the 3rd. I always said I would never have back surgery again, but as a medical advocate, I came to the conclusion that I had a mechanical problem that needed a mechanical solution. So I'm happy to say that I've done quite well. I was discharged from the rehab center in 2.5 weeks after my initial surgery. Was back on the job part-time within just a couple of days after that, and I'm back full-time today. So I'm very happy to be here and celebrate Heart Month with you. So thank you for joining me again. Now, why Heart Month? I mean, we celebrate this every single February, and yet I always take it seriously because of the enormity of the problem. Now, 697,000 people die every year of heart disease. That's almost 700,000. And of those people, coronary disease is the major cause of death, and that affects 382,000, actually almost 383,000. That's a lot. And then 805,000 people have a heart attack every year, and over 600,000 of those people have that's their first heart attack. Now, a person dies of heart disease every 36 minutes. You've heard that. That's amazing, isn't it? But here's the scary part. 45% of heart attacks today are silent, meaning the patients don't even know they have a problem, which is why we have to celebrate Heart, which is why we're going to go over what I'm going to go over, because we don't want people to have silent heart attacks and to have sudden death. So that's my job tonight, is to help go over this with you. So we could talk forever about heart disease, but I brought it down to five important features or aspects I want to discuss this evening. Number one, know your risk. Everybody talks about numbers. How high is your cholesterol? What's your total cholesterol? What's your HDL, your LDL, your triglycerides? Not that those are unimportant, but knowing your risk is so much more important, because I don't really care what your numbers are if you're low risk. And that's what I want to get across tonight. And let me give you a couple examples. There's a 50-year-old female that came to see me recently. She's mild hypertension, overweight, doesn't really exercise. And her cholesterol, these are her readings. Her total cholesterol was 270. Her LDL, lousy, was 144. Her HDL, healthy, was 72. And she had normal triglycerides. And her doctor put her on a statin. And she came to me and said, I don't want to be on a statin. I'm getting muscle aches and pains, and I don't know why I'm on it anyway. So I worked up appropriately with tests that we'll talk about in number two. And I found that she was really low risk. So we stopped the statin. That's just one example. So a lot of patients come to me and I take them off statins because of their low risk status. Your average doctor doesn't really take the time to really go over your risk factors. It's like a knee-jerk reaction. Oh, you got high cholesterol, your numbers are high, you're going to go on a statin. And that seems to be the knee-jerk reaction in this country. This is a recent patient, 54-year-old male, who has a lipid disorder. And in 2018, he had a coronary artery calcium scan, which I will discuss in a few minutes, which was 0. That's the perfect score. But he has this ongoing lipid problem that we've never really handled with the lifestyle. And I'm trying to avoid medication wherever I can. So we did a repeat scan in January of 22, which is 4 years later. And the number now is 25. It's gone from 0 to 25, which is 25th. If you look at his age, and males in that category, he's in the 25th percentile, which means he does, 75% of the population does better than him. So it's important. So what did we decide to do? I could put him on a statin, but he wants to really work on lifestyle, and he's still not that high of a risk yet. So we're going to work with lifestyle and diet before we jump off to a statin. Again, reason why we really need to know it's the risk more important than your actual number. Now, what are the big five? There's 5 different risk factors that you all know about. And the first, actually there's 6. The first 5 are what we call diseases of excess: high blood pressure, smoking, cholesterol, obesity, diabetes. They're all excessive, right? Excessive lifestyle. There's one lack, and that's physical activity, physical inactivity or lack of exercise. Only about 20% of the population is doing what we consider adequate amounts of exercise. Not very good. But there are also lesser known risk factors that you need to know as your own medical advocate, because your doctor may not address them, may not know about them, and may not feel that it may not understand their importance, but they're very important. Uh, tri- Triglycerides. That's another blood fat. Now, we can't, the association between heart disease and triglycerides isn't as well, it's not as well as established as it is with cholesterol. However, high triglycerides is like not a good thing. It denotes a person with a metabolic issue, diabetes, prediabetes, uh, uh, non-alcoholic fatty liver disease, PCOS, polycystic ovarian syndrome. These are not healthy syndromes, and they're usually people that have metabolic issues. And it's really important because only 10% or less of the American population today is metabolically healthy. So triglycerides do have their say so when it comes to risk. LP little a, okay, and I'm going to go with that a little bit. This is an important thing for you to know. LP little a is another risk factor that should be at least determined once in your lifetime because it's genetic. There's no real therapy for it. However, it's associated with coronary artery disease to a significant degree. So it's definitely a risk factor. You should know about it because if you have children, you want your children should understand their risk. So LP little a should be looked at least once. It's a fragment of LDL and it's very atherogenic, meaning if you have it, it tends to be a precursor to coronary artery disease plaque. Homocysteine. It's another risk factor. Most doctors do not draw it. It's a breakdown product of protein. Normally, your body will break it down to methionine and cysteine. You don't have to remember those names. But what happens if you have a genetic variant or a mutation that may disallow you to actually break it down? And that 60% of people have that. So again, if that's the case, you may need to be treated with B vitamins, which is treatment for that. Inflammatory markers. You all know, if you listened to me before, how important inflammation is, not just with heart disease, but with all the diseases of aging, heart disease, cancer, autoimmune disorders, and Alzheimer's. All four of these have inflammation as their common denominator. It's not a good thing. How do you know if you're having inflammation? Well, make sure your doctor orders C-reactive protein, CRP. It's so important. It's amazing how my doctors don't even order it. You need to know your C-reactive protein, and that should be every time you have your blood drawn because it can go up and down. Other markers, genetic markers. Well, I already mentioned about LP little a. That should be looked at. There's another one that I think is important for you to know. MTHFR, which stands for methyl tetrahydrofolate reductase. I know it looks like something else, but it's not. So this is an important genetic test because it tells you whether or not you have one or two variants that cause you to be a poor methylator and therefore makes you prone to high homocysteine levels, which we just discussed. Another one that I think is important is ApoE. Now, ApoE is a genetic test. These people that have this have a tendency to hyperabsorb cholesterol from their GI tract. It's also a mutation it's also related to Alzheimer's. So it's good to know these things because it doesn't mean you're going to have Alzheimer's. It just means you do have a gene for it, and we can take appropriate steps to help prevent it. Other things are those genetic markers, and then of course there's pollution. We know more and more that pollution has a major role in coronary disease, and the big misunderstood one is stress. And if any of you have read my book, and hopefully you have, and I'm going to get it for you in a minute. Sorry. You will see how important stress played in my life at the time of my own my mild heart attack several years ago. So stress is not as well understood, but let me tell you, it's there. So what else? Your personal history. Okay, like I've had a small heart attack, right? I have a history of coronary artery disease. I'm high risk, just by definition. If you have a history of heart disease, you've had a stent, you've had bypass, you've had a heart attack, you've had stroke, you need to be treated more aggressively than someone who doesn't. So that's what we call secondary prevention. So it's very important to know your risk. Also, whether you have peripheral artery disease, meaning artery disease affecting your arteries and your legs, and that's very important as well. And of course, diabetes. Diabetes is considered a risk factor. Why? Because 70% of diabetics will have a heart attack or a stroke in their lifetime. So I look at a diabetic as if they already have heart disease. So again, this is again knowing your risk and why you treat. So we talked about the stress, the actual risk factors. And what about number two? What test do you order? Okay, you have to figure out if how do you know if you're high risk if you don't do testing? Test, don't guess is my motto. So if you have any kind of symptoms, you're probably going to need to have a stress test. And I always couple my stress test with some type of imaging, either nuclear imaging or an echocardiogram, a wall motion study. So I don't hesitate. If there's any symptoms at all, shortness of breath and exertion, chest pain, whether even the chest pain is typical or atypical, because there's so many variations on a theme, and just palpitations, any kind of unusual symptoms that are bothering a patient, enough for them to come in to see me is enough for me to order a stress test. Um, then the next thing on the list when it comes to what test to order is specialized lipid testing. I use two labs that I like very much: Cleveland Heart Lab, which is now part of Quest, and Boston Heart Lab. They're two very excellent labs. They have a lot in common, but they're also somewhat different. One lab offers a few tests that another one doesn't, but they're excellent. Both of them are excellent, and I use them all the time. And that's how you can find out the LP little a. That's how you can find out the ApoE and all the genetic factors, because they test for all of that. And they also look at the size of the LDL particle and also the LDL number. So we all know that LDL is lousy and HDL is healthy, but that's usually all you get when you go to a regular doctor or even cardiologist. So when you do LDL subclassification with these specialized labs, you get a couple of things called LDL particle number and also ApoB as opposed to ApoE. So ApoB and LDL particle number are they're more prognostically significant than just standard LDL. By the way, LDL is usually a calculated value. So it's not even measured directly. And if you have triglycerides over 400, it's not calculated at all. So again, with these specialized labs, you're going to get LDL particle number and ApoB. You're also going to get the size of the LDL particle, which is really important. Anybody that knows me knows that bigger is always better. So these labs measure the size of the LDL particle. So the larger the size, less likely it is to get oxidized and cause plaque in your arteries. And how would you know that? You don't know that. You have to order these specialized tests. So those are your lipid testing. The next one I like to go over is the coronary calcium scan. Now, that is it's a 5-minute test, or probably even less than that. They basically look at your coronary arteries and they detect coronary artery calcium. If you have calcium in your coronary arteries, you got coronary disease by definition. Now, this is an important test because it helps to stratify your risk as far as I'm concerned. If I'm going to determine, should I treat this person or should I not? One of the things I'm going to probably order is a coronary artery calcium scan. That helps me to know where you are. So if your score is 0, which is the perfect score, you have 0, you're at 0 risk. Like that gentleman I told you about, he went from 0 to 25 in 4 years. Now all of a sudden he's 25% risk. But really anything less than 100 is not terribly high risk. Anything from 100 to 300 is moderate risk, and anything over 300, 400 or more is high risk, meaning we know for a fact that people with these numbers don't do well without treatment. Another test that I do that most people do not do is called the pulse test, PULS. However, they have changed their name, and now it's called, I got to look at my notes, it's called the Smart Vascular Diagnostic Test. Okay, now it's a really interesting test because this started off, they studied 250 proteins seen in both mice and human. They found it in plaque. They dissected the plaque out and they looked at various proteins seen in the plaque itself. Well, they eventually went down to 45 proteins. They then used 3 different statistical software systems to identify 9 biomarkers. We're going from 250 to 45, now down to 9. And these 9 biomarkers, much of which you've never heard of, most of which I've never heard of, actually can help determine your risk and also and stratify your risk at 5 years from now of having a stroke or heart attack. So it's not a experimental test like a lot of people want you to know. It's actually been validated by the National Health and Lung Blood Institute, and they actually they confirmed the findings that we already knew, that this is indeed a valid test. And I think it's helpful because it tells me what's happening at the endothelial level. A calcified plaque is a calcified plaque. It doesn't tell me what's really happening at the level of the vessel. But a calcified plaque is less likely to break off and cause a heart attack or stroke. It's the soft tissue plaque, the vulnerable plaque that we worry about. And there's no really way to look at that visually. But the pulse test or the smart TX vascular test gives me a biochemical determination of what's happening at that level. And it's really important because we can treat with supplements. Most doctors are not doing this test. Most doctors don't look at the endothelium. But if that endothelium, which is one cell thick, is intact, I don't care what your cholesterol is, nothing's going to happen. But because of age and diabetes and pollution and stress and poor sleep and lack of exercise and blah, 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 there are little microscopic holes in that endothelium, which allows LDL cholesterol that's been oxidized to get in there and cause plaque. So that's what this test is showing you. It's letting us know what's happening at the level of the endothelium. And it's just a great test for that. So I use it a lot. Okay. So now we know about that your risk is more important than your numbers. We know what tests to order to help determine that risk. Number 3, there are some gender differences that I think are very important to go over. First of all, biology is different between, men really are from Mars, women from Venus. I don't care what anyone says, especially when it comes to heart disease. So there's biologic differences. The hearts in men are larger than the hearts in women, and the coronary arteries themselves are smaller in women than in men. That can make a difference. There's also a difference in where cholesterol is found. Usually in men, it's the larger arteries that we pick up when we do angiograms. In women, it tends to often be the microvasculature, which is the small vessels that you do not see. Okay, that's important. The most important thing, though, is the difference in symptoms. Like this whole thing about crushing pain down the left arm, you rarely see that in women. Women can have chest pain, but more than likely they're going to have shortness of breath, fatigue, sweating, vomiting, uh, pain in the neck, pain in the jaw, pain in the teeth. Women have different presentations. And I have a little rule: if it's above the belly button in a woman, it's hard until proven otherwise. I do not allow myself to get burned. Um, and also, women also are likely to have diseases that can mimic true heart attacks, such as spasm. You can have a coronary artery that tends to spasm down. There's no real plaque, but it spasms down for whatever reason. That can cause a heart attack, but with normal coronary arteries. Then you can have what's called a coronary artery dissection, in which a small vessel from one of the coronary arteries actually tears and will give rise to a heart attack. The other one, when I've seen 2 of these, they call Takotsubo cardiomyopathy, from this Dr. Takotsubo, I guess. Anyway, what happens, an emotional event will somehow cause inflammation of the heart muscle. It'll dilate, actually can go into heart failure, and lead to a heart attack. Fortunately, most of these do resolve in a period of weeks. Also, there's a difference in risk factors. This is really important for people to know. It's not just the standard risk factors. You're a woman. If you've had a history of preeclampsia, or gestational diabetes, we should think, okay, well, it's no big deal. You survive that, you're okay. No, now we know years and years later that gestational diabetes and also preeclampsia is a precursor to heart disease. In fact, it does help predict the risk. But here's the other thing: women with endometriosis, and then talk about women under the age of 40, are 3 times more likely to have a heart attack than their age controls. It's pretty significant. Okay, also men and women tend to have different diagnostic results. For example, there's a test we look for, the laboratory test called the troponin, which is an enzyme secreted by the heart muscle during a heart attack. Now, the numbers can be much lower in women than they are in men, but we don't really have, we need 6 sex-specific thresholds, which we don't have. So again, you have to have a strong index of suspicion because the chemical test that we use may not be as important and as high in a woman as it should be to detect a heart attack. Also, treatments can be different. Like I've put many stents in women and many stents in men, but women also have disease in the microcirculation, which you cannot stent. So you have to just treat these people medically. Okay, so now we've done determine your risk, what test to order, gender differences. Number 4, what is the ideal cardiac diet? I get asked this all the time. I'm going to make it really simple. There is no such thing as far as I'm concerned. Okay. Why? Because there's not one diet for everybody. It really depends. There's so many variables. We've discussed this in the past. So, what's an ideal cardiac diet? Should be low saturated fat and low cholesterol. Can you believe that Heart Association is still talking about this years later? I mean, this stemmed from the 60s and 70s. That saturated fat and cholesterol and fat in general was the villain. And we now know that's really not true. It's not the whole picture. I really don't care about your intake of saturated fat unless it's every day. I'm not a carnivore. But I do have one strong dictum, and that is low carbs. Carbohydrates all break down to sugar, with the exception of vegetables and most fruits. Okay, well, a lot of fruits. So if it breaks down to sugar, it's not a good thing, right? Because we know that sugar is the most inflammatory thing you can ingest. And I always tell people eating sugar is like pouring gasoline over a fire. And we don't want our arteries to be on fire because that leads to inflammation. So there's not an ideal cardiac diet, but basically low carb. I eat egg yolks. I haven't had egg whites since I competed in bodybuilding. That's like so last century. We don't need that anymore. And the fifth one, how do you know if you're having a heart attack? Now, I want to end with this one because I've read like 3 different things on Instagram and social media this week. Long treatise on how to determine if they have a heart attack. And I actually responded, say, you know what? There, if you think you're having a heart attack, if you're even questioning it, get yourself to the hospital. And here's why. The presentations can vary from individual to individual. I rarely see crushing pain down the left arm. I didn't have any of that. I had like heartburn. Okay. And of course, I was pretty clueless at the time. And then I developed a cold sweat hours later that came and went. No chest pain. And then eventually I had arm heaviness. This is all in my book, guys. You'll read about it. So, everybody is different. So here's my thing. If it's something that's foreign to you that you've never had before, or just something that just doesn't, it's bothersome to you, it's worrisome, get checked out. Because here's why, guys. Time equals muscle. If you're sitting home with a heart attack, you're having heart damage done every second. Okay, the quicker you get into the hospital, let's say I'm on call, the quicker I'm going to bring you to the cath lab, and the quicker we're going to try to do our best to open up that artery and spare you of a massive heart attack. Time equals muscle. Don't mess around. If you think it could remotely be your heart, go there, get checked out. And if it's not your heart, we go out and have a party. But I don't want people to have to rely on that. So those are my 5 tips, guys. I'm going to write this down. I decided I should do this as a blog. So I'm also going to do a blog in the next week or so. So it'll be on my page. So now I'm going to take questions. And of course, this is my book, From Both Sides of the Table, When Doctor Becomes Patient. Yes, I did become a patient. I was a patient again most recently. And in case you're wondering, why would I undergo second surgery when I was adamant in my book that it would never happen again? Because I didn't know what was going to happen. I always left that possibility open, but because I was really losing it the last 18 months or so with my balance and my strength and my mobility, it was looking pretty bad. And my partner said, I see you every day. You're not doing well. And I promised him before he passed that I would proceed with the surgery. And I'm doing so much better already. It's just been 5 weeks. So you do use your medical advocacy when it comes to making decisions, because that's very important. It's all in my book. Please get it. You can get it go to my website for my book is BeYourOwnMedicalAdvocate.com. And you can go on to the links where it says buy now, and it takes you to my Amazon page, and you can get it for $9.95 the Kindle, or I think it's $18.95 for the softback edition. And I always ask people if they could please write me a review, because reviews really make a difference. I want to make this book a game changer. To make it a game changer, I need to make it a bestseller. To make it a bestseller, I need sales, and I need reviews. With that said, let's look into some of your questions. Okay. Am I implying that women are different? Absolutely. I mean, there's no question about it. That old thing that, what's his name, Gray, that men are from Mars and women from Venus, is true. And that's why I made that into a major point I wanted to get. So there are gender differences. So it's really important. Okay, let's see. Test, don't guess. That's really it. Test it's so important, because how do you know you're high risk if you don't know the test results, and so many doctors don't do LP little a because there's no real treatment for it, or they don't do ApoE, or they don't do MTHFR. Once you have this information, folks, you got you can act on, and it's really important. So I do. To me, it's very, very important. Okay, what is the best nutrapharmaceuticals for heart health? Okay, those are good questions. Um, Probably okay. Well, I have a four. Number one is coenzyme Q10, and my mentor, Dr. Steven Sinatra, taught me about this many years ago. Unfortunately, he passed away this in June. But with CoQ10 is very heart healthy. Every cell in your body needs to produce energy, okay, 24/7. Well, the heart does for sure. And so to have adequate CoQ10, it's really important. Um, it's a nutrient for the heart. And here's the thing: statins, which are very popular, will deplete you of CoQ10. We want the statins to interfere with liver production of cholesterol, but we don't want it to interfere with the production of CoQ10, which it will. So whenever I prescribe a statin, I always make sure the patient takes CoQ10 with it. It's a must. It's also good for heart failure patients because it helps with the bioenergetics of the heart. So that's my number one. Number two, L-carnitine, because L-carnitine actually brings fatty acids from the inside of the heart cell to the mitochondria. Mitochondria is your powerhouse of the cell where energy is produced. So think of L-carnitine as your carrier molecule. It carries the fat where you want it to be in the mitochondria, and that's where you can uh, burn energy. Okay, and the other one is D-ribose. D-ribose is a 5-carbon sugar as opposed to glucose or sucrose, which are 6-carbon sugars. So even diabetics can take it. It also helps with the energetics of the heart. So I use those three for sure, and also magnesium, which is this trace mineral. About 60% of us are deficient in magnesium. It's very important for heart health and and your health in general. So those are my four biggies. There are other ones you can use as hawthorn berry. These are the four that I have stuck to all these years and get you to use. Okay, let's see. I'm looking at my questions here. I know, yeah, the MTHFR. Yeah, I know what. I won't say what it looks like. That was my first. What? But yeah, it's methyl tetrahydrofolate reductase. It's an enzyme, and it's all dependent on your genes. Okay, and let's talk about genes for 1 second. Because I have people say, "Oh, it's in my genes," or I got bad genes. Let's make one thing. I'm going to make something perfectly clear. Your genetic makeup probably constitutes about 30% of your clinical outcomes. Okay, 70%, folks, is based on lifestyle. We now call that epigenetics. So don't tell me it's all in your genes. Yeah, you can be a victim and make that happen if you want, but you can also be proactive, which is what we all do when it comes to being our own medical advocate. And we don't allow our genetics to take over. Like I have the MTHFR, I have a variant, both two variants. Okay. My numbers are always normal. I don't know why. I mean, my gene is obviously switched off. And I like to think it's because I have a healthy lifestyle. But, a lot of people have that same variant I do, and their homocysteine levels are through the roof. So it's all part of it. Okay, is aspirin still valid? Great question. I really like that one because someone told me well, I don't think I've been told aspirin's not important. If you've had a heart attack or a stroke, or you've had a stent or bypass, or you're very high risk, yes, it's still indicated because you want to prevent a second heart attack. You want to prevent a blood clot from getting and causing problems. Now, it used to be, I was never of that school that anybody over 55 goes on aspirin. I never believed in that. I always took it on an individual basis. So how I do it, if you've had a history of heart disease, yes, I would probably do it I would do it for sure, for life. Diabetes, probably yes. If I have multiple risk factors and a high calcium score, yes. So that's how I do it. I don't like an all or none kind of rule. Like no one should be on aspirin after the age of 55 anymore. Those studies were done on a general population, and they found out in the general population that there were more bleeds in people taking aspirin than not. But they didn't really break it down into who's got heart disease and who doesn't. And that's why risk stratification, which is what we're doing tonight, is so important. Great question. Let's see. We talked about heart health. Um, Anything else? We talked about genetics, we talked about tests, talked about risk. I talked a lot tonight, but it was important, and I'm going to repeat some of this. I decided today, maybe I'll just make a blog out of it because not everybody is going to be watching this. So I'll have it written on my website soon. But anyway, I don't see any other questions. So I want to thank everybody for coming, and we'll probably do another one. I'll try to get one more in the month of February if I can do it. My partner was also my art director, so I'm kind of working on my own right now with some of those. But anyway, we'll do another one soon. And I thank you for coming. Please get my book, write a review, and please subscribe because you'll be given alerts as to when we go ahead and have ongoing things. Okay, thank you guys. Thank you so much. Have a good night, and we'll talk soon. Bye bye now, and happy Heart Month to everybody.